Good afternoon, everyone, and thank you for joining us for the May Action Period call for the Smoke Free for Me Learning Collaborative. If anyone is having any issues with the webinar link, if you just send me an email, I'll make sure to respond and help you get logged on, but I'm seeing a lot of folks are logged on. So I want to go ahead and get started. I know we may have folks joining us in a few moments, but we have a lot to get through today, so I thought we would go ahead and get started. Again, a thank you and a welcome to our program partners from the GRC, MedTap, Ohio Partners for Smoke-Free Families, the Ohio Department of Medicaid, and Ohio Department of Health, all of whom help us administrate this program. And some of them, I believe, are joining us on the phone today. So thank you again for all that you do to help us with this project. I just wanted to briefly go through the agenda, and then we will get on with our speaker for today. So first we're going to do a quick roll call just to see who all is joining us. And then we have a presentation from a staff member from the Ohio Quit Line on the efforts in Ohio to reduce tobacco dependence. We're going to do our monthly run chart review, and then we'll have a quick wrap-up at the end. So just wanted to get a sense of who we have on the call. Do we have someone from Akron Children's Hospital? Cornerstone Pediatrics?
Hey, Dr. Sweat here.
I'm sorry, who was that again?
Dr. Sweat.
Oh, Dr. Sweat, thank you for joining us today. Children's Medical Center, Middletown? Cleveland Clinic, Euclid. I know, Dr. Hornick, I see that you're logged in to the webinar, so hopefully you...
yeah, I'm here. I'm here now.
Okay, great. Thank you.
Mm-hmm.
Cleveland Clinic, Medina. Cleveland Clinic, I know Stephanie Tubbs-Jones cannot join us today. COPC, Eastgate Pediatrics, Fairfield Primary Care, Group Health Anderson,
Denise Warwick.
Oh, great, Dr. Warwick. Hi again. Ohio Pediatrics, the Christ Hospital.
Hi, it's Elizabeth Lazaron here. I'm on the audio part. I'm having trouble getting onto the webinar, so hopefully I can listen along till I can get this link to work.
Okay, and I will send you another link just to see if a refresh link would help. And University Hospitals, Medina.
Yes, Lisa stepping in for Dr. Karen Hummel. And I also, if you could send me that link. Hi, how are you?
Yeah. Good. Thank you for joining us. And then I know I heard Dr. Hammond earlier from Wheeling Pediatrics. And then it looks like we have a few of our partners joining us, Rhonda, Arun, and Alicia. Is there anyone else on the line from ODH or ODM? All right. Well, we will get started. I want to welcome Amy Garinflo from, she is a Cessation Services Program Administrator with the Tobacco Use Prevention and Cessation Program, and she is going to talk to us today about efforts to reduce tobacco dependence in Ohio, and then also additional information about the Quit Line. So I will turn it over to Amy.
Hi, good afternoon now. Thank you for having me. Just a few things here to start out. The slides are going to be advanced for me, so you're going to be hearing me do that. I apologize. And I start all of the presentations I do with a little bit of data. So if this is, I'll try to go fast because I know that a lot of this information is very familiar to most of you as I'm listening to the roll call there. So if we want to start with the next slide. So we talk a little bit about the smoking rate in Ohio. So it's declined since 2011, But the 2015 BRF-SS survey tells us that about 21.6% of adults in Ohio are current smokers. So that equates to about 1.8 million smokers. So we know that although our rates have declined from a 25.1% prevalence in 2011, we know we still have a lot of work to do, and I know a lot of us here are directly involved in that. So the next slide. Okay, so we like to show of the 1.87 million smokers we have, how many are trying to quit. So you hear from, I think a lot of you are speaking with parents that come into your practice. We know about 3 of every 5 Ohio smokers made some quit attempt in the last year. So the way that's defined in the BRF-SS survey, in case you don't know that, is those that have tried to stop smoking or had stopped smoking for 1 day or more in the past year because they were trying to quit. So it's not on days they were sick or days that they maybe couldn't afford cigarettes. We do see some of that. It's that they were actually trying to quit. So we do know that while we do have a lot of smokers to do, there are a lot that are also trying to quit. So it should be the perfect storm there, although we know we need to link them to resources, and that's one of the reasons I'm here today. The next slide. Here we talk a little bit about, this should be no surprise to any of us, that we're seeing the majority of smoking, the highest prevalence of smoking are in the Medicaid populations, and then, kind of the uninsured groups as well are kind of right there neck and neck. And we see the lower rates among those that are privately insured, some lower rates for those that have exchange coverage, some employer-sponsored health insurance, which is sometimes a little bit different than the private insurance plans. But we do know that we see at least twice the rate of smoking in the Medicaid population. Next slide. A little bit here about disparity. We give this presentation sometimes when we're talking about specific groups that experience a higher than average burden of tobacco disparity. We know that the impact here is seen, again, we talked about those that have low income, but then also the low education. There are some of the higher rates. The LGBT, those that identify as being LGBT, have higher rates, and we are starting to see for a while there really, and in this slide it shows that there really is no significant difference between Black Ohioans and just Ohioans in general. But we are starting to see some of that break away a little more, as we are starting to see in some of the newer figures that are coming out, that we are starting to see a little bit more of a disparity in the African American population. So again, here looking at just the disparities with the largest tobacco use disparities, and this may be of interest to you as you're addressing tobacco use with certain groups, just knowing that they're a little more likely to smoke or use tobacco. Next slide. Okay, so talking a little bit just briefly here to kind of set the stage for some of the things I'm going to be talking about. The cessation activities with our program here at the Department of Health, I am part of the Tobacco Use Prevention and Cessation Program, and I primarily handle all of our cessation activities. And then we have other programs. I know Rhonda's on the call with Smoke-Free Families. They are addressing maternal tobacco use as well as, our program does address that as well. But primarily our tobacco use prevention and cessation program, with regard to cessation, we monitor and contract for the operation of the Ohio Tobacco Quit Line. And we use a vendor for that, and presently it's National Jewish Health, and actually they have been our only vendor. They continually win the bid that goes out every few years competitively, and they have been our vendor since Ohio started the Quit Line in 2003. So they've always been our vendor, and like I said, we've put it out for bid several times, and they've always been able to kind of win. Well, they've always been able to win that bid. The second largest bucket of cessation activity is we promote the availability of local cessation services. And I'm going to talk about that in a little bit, but we're constantly trying to reassess where we are across the state. We know the Quit Line isn't for everybody. We know that there are barriers to using the quit line as well as barriers for some to using the local services that are available. So we're always trying to just get the full picture of what we have in our state and work in areas where we're needed in terms of offering funding. We have not offered cessation funding prior to this past year. It's been the first time in a very long time, and certainly the first time since the Tobacco Cessation the foundation funded with the Master Settlement funding dissolved in, I think, 2007. So this is the first time, we'll talk about it later, about that our program has funded cessation activities. And then the third thing we do that doesn't really fit well with any of our other, it's woven into our other activities, but we do execute media campaigns and promotions. And the CDC Tips from Former Smokers campaign has been wildly successful in our state. It kind of varies by year. There was a Ohioan a couple years ago. You're probably, hopefully familiar with the ads I'm speaking about here, where we have those hard-hitting messages about the impact of smoking, and it's tips from those people that have usually, well, always experienced some sort of impact or consequence of their smoking. The person from Ohio was not very old. She was in her late 40s and had been diagnosed with COPD and was 100% dependent on oxygen, and was talking about her life now and what that is. And she's not even, really hasn't reached middle age yet, or is just getting to middle age and has her whole life ahead of her and is really very dependent on that oxygen tank. There are others that are, the one out now is a light smoker, where her ads are really, really impactful in that she's, half her face is gone from a smoking related illness. So these ads have caused a lot of really major increases in calls to the quit line. And from what we know of, you can't scare someone into doing something, but these really have shown to kind of buck that myth or buck some of that data that we had before of how people have to do it and not really be scared into things, when really we are seeing people that are truly ready to quit. These ads are really kind of pushing them toward making that change and have really resulted in a lot of people successfully quitting. So next slide. So the Ohio Tobacco Quit Line is accessible by calling 1-800-QUIT-NOW. That number is a national portal. So for those of you that are on the border, I heard someone say they were from a Wheeling hospital, I think. The calls are directed, and not a lot of, this kind of isn't public knowledge. It makes sense once we explain it, but the calls are directed, with it being a national portal, it goes by the area code of the person calling. So if you have a person that's in Ohio, that's they for some reason have a cell phone carrier from West Virginia, they will get routed to the West Virginia quit line. And that can be a little confusing sometimes, and we've had situations where other quit lines around us, the state contract dictates what service that quit line will offer. So not all the states around us, unfortunately, have the same coverage, and really they don't even have to be around us. It goes by the cell phone carrier. So somebody could have moved from California to Ohio, and they're going to come up as get routed to the California quit line. So that sometimes can cause a little bit of confusion, especially if you're hearing from your patients, they didn't serve me, or I didn't get something. It kind of alludes to some of the things I'm going to discuss later, of some of the things we hear and the checklist we go through in terms of troubleshooting. I'm getting a little deep in the weeds with that there. Sorry about that. But that's something we always like to explain, is that it has to be an Ohio area code for that person to go directly to Ohio. That doesn't mean that they don't eventually get to Ohio, but when they start telling them where they live, they should be routed to the Ohio quit line. It doesn't always happen, depending on, again, what happens in the other states. They may go ahead and serve that person, not realizing they are from Ohio for whatever reason, but that does happen sometimes. We do see that. So it is telephone tobacco cessation treatment offered by trained professionals that have had extensive training in tobacco dependence, and Ohio actually has a coach-only model, which means from the time the phone, from the time the call is picked up, it's a coach that's speaking to the individual. So it's not, some states have an administrative person answering the phone and then transferring to a trained coach. In Ohio, we found that it works better for us to have build that relationship from the very start with someone that knows about tobacco dependence. Right now, we have up to 8 weeks of the participant's choice of nicotine replacement therapy available. There are some caveats with that I will explain later, but the take-home with that is the individual has to be enrolled and participating in the calls to get that replacement therapy, and it's not doled out at once. It's 2-week shipments with each call the person participates in. There are also some web-based services available with facilitated chats. That's a new feature that we're still kind of looking to see how folks are doing with that. That facilitated chat piece is new. Website's been around for quite a while. There is text messaging available in both a general format, and then if someone identifies as having a certain chronic disease, that they will also be enrolled if they choose. It's opt-in to text messages based on whatever chronic disease they may have. So if they're diabetic, their messages will be customized to someone that's quitting while maintaining their, considering their changes that might happen with their blood sugar. Quitline can be accessed through self-referral, so you see a commercial on TV, your provider hands you a brochure, you call the Quitline yourself, or a provider can choose to do a fax referral, talk with the patient about it, have them sign, it gets faxed away to the Quitline, and then they will contact the participant. And then electronic referrals are coming soon. We have them up and running in one. Metro Health in Cleveland is doing an electronic referral project, but we're going to try to make more of that available. There are just so many different integrations, and I'm sure I'm talking to a lot of you that know about this. There are just a lot of different moving parts when you're setting up an electronic referral system. Next slide. So eligibility for services, this is something else that comes up every once in a while. The Quitline didn't serve me for whatever reason. It's usually that the person has some sort of private health insurance. But right now, eligibility for services, all Medicaid recipients, those that have Medicare, the uninsured, pregnant women are covered regardless of any other factor. So they could have a private health plan, but they are covered regardless of any other factor. And then members of the Ohio Tobacco Collaborative, some participation varies with this, and so we try to just have, if you have someone that's interested in quitting and they're interested in Quitline services and they have a private plan, they may still have their private plan, may still be covered through the Quitline. It's going to be the exception to the rule, but it could be possible that that private person, the person with private insurance, Anthem, Aetna, whatever, does have coverage. So we just say refer them. We'll take care of screening them for eligibility. At the very least, we would refer that individual, if they aren't eligible, to whatever services we know are available in the county they're calling from. So if you're comfortable with that, that's something you can do. It's not always something that the person's going to end up being enrolled and getting replacement therapy, but we can at least talk with them and screen them for eligibility. We do have periods of time where we do have extra funding from CDC and we are able to cover everybody, and that's another reason to go ahead and refer them, because it may be during a period of time that we don't shout it from the rooftops because it can be very confusing, but we are sometimes able to cover everybody. The web-based services, however, are available to anybody in Ohio, so there's not an eligibility factor there. Next slide. The pregnancy protocol I mentioned, and this may be of particular interest to those of you that are working with pregnant women, this protocol is designed specifically for this group. They do have a dedicated coach model, which means they will schedule their appointments with the same coach every time. Pregnant women get more calls. It's 10 versus the normal 5-call protocol. There are some monetary incentives associated with call completion, and then it does follow the participant for up to 6 months after delivery. So that's a time when we know relapse is common. The woman is very concerned about the baby when she's carrying, and then when the baby's born, maybe that not as concerned, even though we know she should be because of secondhand exposure. We know that time relapse is very common. Next slide. And then we do have a behavioral health pilot project going on right now. I just wanted to throw this in here because it is something we're working to look at the quitline experience for those that identify as having a behavioral health condition. This is kind of follows the same format as the pregnancy protocol. What's different about it than our normal treatment protocol, but we do have those customized emails and text messages. They get a little more replacement therapy, a specialized treatment protocol that is developed by the former clinical psychologist that was the medical, or not the medical director, was the, at National Jewish Health. She was with National Jewish Health. She since left, but she did develop the protocol, and she is a clinical psychologist, I believe. Next slide. Okay, so what happens when you call? The call is answered by a coach or counselor. I did go into that. There is an intake questionnaire the participant completes. Because it is with their coach or counselor, this does elicit a lot of discussion that it doesn't necessarily feel like they're taking a questionnaire. They go through some smoking habits, past quit attempts, talk a little bit with them about what's going to happen when they go through the process. The first coaching call does take place at the time of the first call. So unless a participant opts out. So someone may say, I called the quit line, I told them I wanted replacement therapy, and they never sent it. They never sent it to me. We are hearing that sometimes. So what possibly happens is the participant was told they would get the replacement therapy. They said what they wanted to have. Then they opted out of starting the first coaching call, so the replacement therapy wouldn't have been sent, because you can opt out of the call if you say you don't have enough time to stay on. That intake questionnaire can take a little bit of time, especially if there's some extra discussion. And if someone is dependent and they need to go out and have their cigarette, they're not smoking in their home, they'll cancel out of the call, even though they're probably calling from a cell phone, cancel out of the call, and then choose to schedule the next call. So if they never participate in that second call for whatever reason, they've decided the time's not right for them, for whatever reason, they wouldn't get replacement therapy because they technically didn't participate in that first call. And that kind of leads to this next discussion here, that it is shipped after each coaching call, the replacement therapy, and that's up to 4 times. So it's 2-week doses sent with each completed call, up to 4 shipments or 8 total weeks. And then with pregnant women, we do require that they have the medical release from their physician before we will send that. And then they do schedule when a participant is involved in the call, they schedule the next call. They are invited and encouraged to call back whenever they may need some extra assistance. That's not the part of the standard protocol, the 5-call protocol. Those are the scheduled calls that the same thing happens at each call is scheduled to happen with each call. So we're talking about triggers in the beginning. We're talking about preparing for quit date. There is a protocol for each call. But if someone finds that they've quit, they quit 5 days ago, they have an event, they're going to go out with their friends, and they're worried about how they're going to handle triggers or handle the situation, and they decide to call and want to speak to a coach. That's a ad hoc call. That's not part of the regular protocol. So they can have additional calls as needed. That's something we always like to explain too, because it doesn't necessarily have to be something that's scheduled. We know that life happens, and the quit line is open 24/7. Next slide. So I see the time getting to about 12:25 here, and we're trying to get you through here. So we have some data in here. I will send you the presentation, but we know that quit lines work. They're evidence-based, research-validated best practice. Let's move through some of these a little quicker, because I know I wanted to get to the point of questions. This goes really fast. So research-validated best practice, 27% more likely to quit, and then the use of NRT increases the likelihood of quitting. That's why we've chosen to up the availability of that NRT, because we were hearing from our participants, we very regularly evaluate the quit line and evaluate the service and talk to participants and try to find out, what's worked for them. And a large amount of the time they're saying that the NRT is really what's helped them. Next slide. The efficacy of text messaging, we know that that's something that's promising right now, and we've had it for a long time, and then added the chronic disease 2 years ago now. Next slide. Cessation medications, 1.84 times more likely to quit than the placebo control. And then again at the bottom that we do have the 8 weeks available. Next slide. Sorry, I know I'm rushing through here. The ways to increase engagement. This is one I really wanted to get to with you and have you hear the ways that we've identified when we hear something's happened. If the participant goes, they go back to their doctor and says, oh, they never called. These are some things that we've identified. We always welcome you to provide us with the name of someone you've referred or any identifying information so we can pull it out of our data and look and see what happened to that participant. Many, many times, because we're dealing with the dependents, we find that something has happened, that the person has told their provider they want to quit, they've been sent the referral, and then when we call them, they just say it's not the right time. Or it's possible that they don't recognize the number. I have on here the actual number that the call will come from. It's in Denver, Colorado. It does not say Ohio Tobacco Quit Line. It's unfortunate. We've worked on ways around it, but it is a call center. So the phone number can be identified at the time of referral. You can suggest that the patient puts it in their phone, so it'll come up Ohio Tobacco Quit Line. That has been a huge something really important to do to increase engagement and ensure that when they see that number, they know who it is. Yes, messages are left. You don't always pick up your messages. You don't always recognize. Now, I don't answer numbers I don't know, and that's important to try to, if you can think about it and you can integrate it into your referral process, all the better. It's going to help get that person engaged in services. And share what to expect. We've talked about it here. We're going to send the slides. We've talked about what the person can expect when they get that call. Next slide. CCI, I wanted to throw this in here when I talked about our funding for local communities. These are some new projects that we funded. The local public health and community are addressing tobacco. They are charged with being, it's all public health departments except one is working with a hospital, and they are the local hub for community cessation. So they will, they're looking to contract with providers to offer services. It's a referral network. It's tailored to the community, and then we're also including some relapse prevention through long-term follow-up as part of that. And it's really rigorous evaluation, and we're looking very closely at our outcomes relating to this project. And I'll send along that, I think, if I didn't already, I'll send along the one-pager with all the contact information for these counties. Next slide. Oh, there they are. I included it here. So these are the counties listed, and they really do reach 20%. If they do what they need to do and get all of the reach going here and get all their providers in place, which they are working diligently to do that, they have the ability to reach more than 20% of all tobacco users in Ohio, just based on their population and their prevalence in each of those counties. Next slide. Questions. I wanted to get to questions. So more than happy to provide I think my contact information is on the next slide if you want to contact me directly, but are there any questions now?
The county initiatives, they look mostly, other than I think Franklin County, they all look like rural counties. Was that on purpose that you chose rural counties, or?
Actually, the funding was, Franklin and Lucas are both urban counties.
Okay.
Licking is we actually funded based on their distinct OMOS county distinction. So we had 2 urban counties available, and those are the 2 that won the competitive. It was a competitive RFP. Licking, Knox, and Perry actually has, one's a suburban, one is an Appalachian, and one's a non-Appalachian rural. Huron, Erie, and Sandusky are kind of rural, and then Carroll and Belmont are. It's just the way the application process went. And it was by design that we would have different county types, certain numbers in each county. But Franklin and Lucas are both urban areas.
Okay. I'm surprised you don't have Cuyahoga, which is the most urban.
It was a it was a
RFP,
competitive RFP. So yeah,
gotcha.
if they if they had applied and won, we would have funded them. Yeah.
I gotcha. Thank you.
Yeah. We didn't choose them, they chose us, I guess is one way to look at it, although we did score the proposals. Uh-huh. Are there other questions? Okay. The next slide should be my contact information, I believe. Oh, no. Some closing thoughts. We've already covered all of this. The next one should be my contact information, as I was run 1 minute over. Sorry about that. Feel free anytime.
Thank you so much for joining us.
Yes,
thank you.
That
everyone gets a copy of the slides so that they'll have your contact information, and definitely appreciate the partnership with the Quitline with this project. And thank you for your time today.
Thank you. Thank you.
Thank you.
All right. And so with that, I will turn it over to Sam, who is going to do our monthly run chart review. A reminder that this is for data that was submitted from April 8th through the 1st of May. And so I'll let her get started.
Thanks. All right. So like we've done on previous action period calls, just refocusing us to what we're trying to accomplish and the different reasons that we are emphasizing measures and the different components of the screening tool that you guys are deploying within each of your clinical flows, but incorporating the 5 A's intervention to make sure we're getting the tool out there and checking on positive screens for those that do indicate that they are smoking, that we're offering caregiver referrals to the Ohio Quitline for those that do screen positive for smoking and vaping, and that we're providing information and resources to those presenting caregivers that they can give to other individuals within their home. The data that we have outside of the current run chart that's on the screen is going to look a little different as I present it today, and then in your practice level data, we had GRC work with us to kind of narrow down and dig into the data to see what component of some of our multi-pronged measures may be impacting or pulling down a specific measure so that it's not reaching the goal, and that's what I'll be focusing on today. So here we're just looking purely at smoke exposure with others in the home, and that's indicated in the green line. The caregiver that's coming within the office for the well child visit in the dark blue, and then that light blue line is just any individual within the house that is smoking. We're still kind of hovering. It looks like a little bit of a downward trend. We'll have to see how that continues throughout the collaborative, but right around 15% of individuals within the home are smoking. And first and foremost measure that we've been working on so that we can impact the rest of the measures down the road is getting that screening tool into place. And we were able to speak with the majority of you on our touch bases, those 15-minute phone calls that we had with either the physician lead or different people of the quality improvement team to chat with you about how everything's going. And I think this past month, the data that we've had submitted for April speaks to the work that you guys are doing, and that we've gotten to our goal of 90% of the time getting that tool out to individuals with families birth through 1 year of age, small child visits, and then continuing to not only meet that goal but work to get every individual screened. Now this slide and the following slide breaks down that data. So we have, and it's busy, and I know the lines are a little small, but we have a lot of practices that are participating. But we wanted to just kind of give you an idea of how everyone's doing. So I'll just pause here on this slide, and then on the next slide, if you don't see your practice on this one, to let you see how you're doing. And then if anyone has any comments that they would like to share with the group that maybe you mentioned on our touch base call, or something that's just really worked for you that got you to get the tool out to all those families that are coming to the practice, or just kind of anything that you'd like to comment on, that you see within the data here, I think it'd be a good opportunity to share some of those lessons learned with the other practices on the call. I'm going to move to the other side so the other half of you can see how you're doing. And then, of course, feel free to unmute and chime in about any thoughts that come to mind about getting this screening tool out into practice.
So, Sam, this is Kristen. One theme that I'll mention that I think we heard in the 15-minute touch base call was sort of pre-planning. I remember hearing a number of practices talk about sort of taking a look at the schedule for the week, knowing who should be getting the tools, and then kind of having a system in place for that. Some of the trouble spots that tended to come up were some practices would have staff turnover or someone out who was responsible for a certain piece of the workflow, and then tools, screening tools wouldn't get put into place, basically. Those were, from my recollection, some of the themes that we heard in the calls. I don't know if you had other ones to share.
I agree. I think that would be the gist of what we heard on the touch base calls, and then, of course, the first and or second PDSAs that each of you have submitted to date drew upon, how to establish that within your clinical flow, having a point person, figuring out the best place to deploy this tool, be it in the waiting room or kind of room, who's storing it, and kind of putting those different things into place. Okay. Well, if you guys do have anything you'd like to comment on, please share. The next slide, and then the ones that come for it, break down what each of these multi-pronged measures are comprised of. So we have our goal line in red, and the dark blue line is the percent of individuals or caregivers who came to the office, and this includes both those in the office and those that had a smoking individual within their home who were given resources by the provider. And then there's a breakdown of this. So the smoking resources provided is comprised of two things that need to be met. You have given a resource, and you've offered a resource, and you've tried or attempted to have a discussion about the smoking situation. And we wanted to see what may be that item that is not allowing us to kind of move the needle and bring us up towards the goal. So we've broken these measures down where in green we have the caregiver that's in the office, how many of those individuals had a discussion. In purple, the caregiver that's in the office, how many of those had a resource offered. And then very similarly, in the light blue, for another individual in the house that is smoking, discussing that. And in orange, providing or offering a resource for another individual that smokes in the home. And the theme that I saw and that you'll see as we progress the slides is that the resources, the purple and the orange lines in each of the measures, is what is pulling some of these items down. And I'll go to the two following measures where we look at this by practice. Again, your colors are the same colors that they were in the previous slide, and we're broken down half here and half on the next slide to look specifically at that smoking cessations being provided and resourced to see if anyone had something that they would like to share that's really helped them or something that they feel is hindering them in giving these resources or having discussions with caregivers.
I've got a question. Are these like, is this just looking at smoking cessation resources, or is it also looking at like the safe sleep, breastfeeding, stuff like that?
So this is just the resources for smoking. On the slides that are specific to safe sleep, I have it broken down that way as well, so you can see that. But throughout most of these, it does seem that it's the resource component of these that is pulling things down.
Okay.
And we were hoping that with it just that you are offering a resource. The family does not necessarily have to accept, but just as like you're trying to have a discussion with the family, they may not be open to it, but you have taken that step, you've tried to open the conversation, and you can select, yes, I've tried to have a discussion with this family, or yes, I tried to offer a resource to the family and that would help. So I don't know if it's maybe looking at it with that frame of mind, or if it's still kind of a resource that families just don't want or we're not offering them, kind of getting down and figuring out what is that component. Any thoughts?
Well, I know this is just me personally, but sometimes if it's like the mom usually who's there, if she says something like, no, I'm not really ready right now, or something like that, a lot of times they can be a little defensive, and so at least like my feeling, and this hasn't even come up that much, but is that if then I'm sticking a handout at them after they've kind of already said, no, I don't really want to go there today, that they're that might damage our therapeutic alliance.
Okay, so they're indicating some level of readiness, probably a 2 or above. It could just be a 2, but that still then is you, within this measure, need to offer a resource, but as you're in that environment and situation, it's maybe not appropriate because they've kind of given you a tone, or the encounter has indicated it's not a good point to do this.
Yeah, because usually I don't go in there with the handouts because I want to, get a feel for where they're, at. Like if they're ready to, I'm going to be having them do the quit line and give them all of that stuff. But this definitely kind of came up like more in like the bronchiolitis season where, people were kind of going like, I know the smoking is bad, but I have this toddler and this baby is keeping me up all night wheezing, and if I stop smoking right now, I'm going to kill them, kind of thing. And so, in that case, I didn't want to be looking pushy.
That makes sense. So it's a little more than just what's on the tool. It's what's happening within the encounter that's kind of
right. Exactly.
That makes sense. Okay. Any other thoughts from other practices on the line? Okay. Well, thank you for sharing, Dr. Harvey.
Yes,
go ahead.
Elizabeth from Christ Hospital. So one time we found people are really resistant is when its family members are having a babysitter who's maybe free, maybe another relative who's a smoker, and they feel like they can't jeopardize that relationship by discussing stop smoking with the other caregiver for the child because of, babysitting commitments and whatever, losing that resource if they address the smoking. And that's one thing we've heard more than once. It's probably been a handful of times we've had that conversation.
Okay. And those handful of times really do play into these measures because, as you can see here, it's 85 individuals for this whole collaborative. So if you have a handful of times, that's certainly going to pull the measure down, and that makes sense. So these are good pieces of information to have as we're looking at this and figuring out how we can come at it from different angles or what may be impacting our resource provision or our discussions.
Yeah, I've had some patients who are living with relatives because they have to, and the relative is a smoker. And so same thing, they don't want to jeopardize their room and board, or their room that they have, by confronting the relative that they are staying with, that they are living with.
Okay, so some parameters are outside of their control, or a situation that's really confining them to having that conversation.
Correct.
Okay. Well, based upon that, it sounds like a lot of the barrier may lie with other individuals within the household, and that's what this measure that's currently on the screen looks at. So you can see that purple line is basically our rate-limiting step here, and is not allowing the measure to really go up much higher. We can see that you guys are certainly attempting to have discussions, and that's hovering around 80% of individuals having a discussion about other individuals smoking within the home, but giving a resource may be a challenging component. And then similarly, this one is for those caregivers that are in the office with the child. The caregiver resource, again, is the limiting factor here, and you're having discussions over 80% of the time. So I think having those items in mind are really helpful as we look at as what we see with the measures being broke down as a resource being a challenge, but there are other limiting factors that aren't just black and white on the tool that come into play when we're having these discussions with families. So then the following measure is our use of 5As with the smoking caregiver. So the first two components of this is having or attempting to have a conversation with the caregiver, offering a resource, and then the addition is in this green line, the offering to go to the quit line. So we can see here that that's a bit of a challenge with having referrals offered. Again, I think a lot of what you have discussed with other individuals with the home or the actual caregiver during bronchitis season, different factors that are coming into play with having referral. Anything else when you're looking at that component of the measure with the referral to quit line that you'd like to share that is making it hard to offer this resource to smoking caregivers? Okay. And then this slide just reiterates what is comprised for that measure. So attempting to have a discussion, selecting yes, offering a resource, selecting yes, and then whether or not the MD has offered the referral, it could be accepted or it could have been declined. And those three prongs are what we fold together to get that measure. And then this one is the caregivers who accept the offer of the referral to quit line. And I think Dr. Hardy mentioned with the level of readiness that there's maybe too much on the plate at this time to do that. They know that they need to do it, but it may be addressed at a different visit. So this is kind of all the work that you guys are doing, trying to see of those that you've had the conversation, given a resource, and offered the quit line, how many of those are actually accepting. Any commentary here that you think is playing into that acceptance of the quit line that hasn't already been mentioned? All right. And then this just
Sam,
reiterates.
This is Kristen. Sorry, I just wanted to, I think this might be a good point to mention this. We did hear from one practice who mentioned that oftentimes when she had a parent or a caregiver who refused the referral to the quit line, they said just wasn't the right time, they kind of weren't willing to take that step, that she had noticed that when she would attempt to do some sort of short-term goal setting with them around decreasing their smoking, that she was having some success with that. So she was sort of indicating, she would accept their non-acceptance of a referral to quit line, but she would still try to set some short-term goals, and that she was noticing that they would accept those. They might change the location of their smoking or cut back. And, she would kind of check in with them and then obviously look at the responses on the tool the next time. And she was noting just anecdotally, she felt like that was working some for her with the caregivers of her patients.
That's right, the incremental behavior change and moving our way towards having that referral be the ultimate outcome, but not forgetting that there are baby steps that get them there. Okay, and then this slide just shows that this is solely the acceptance of the referral as we've taken out the no decline. So just purely of those individuals, how many actually accept. And then the last slide is on the safe sleep resources, and Dr. Hardy, you had asked if this plays into these as well, if it was just a smoking cessation. And you can see here in the purple line that it is the resource that is the lowest component of this two-prong measure. While you're having safe sleep discussions like 70, 68% of the time, it is the safe sleep resource component that is not being checked or met that is pulling down the safe sleep measure. Any commentary on that from practices? I know we had conversations with a few practices on the touch base calls about when they actually give the resources, how often or how frequently they give them based on the age of the child or the well visit that they're attending, and some of that did play into how they were selecting whether or not a resource was offered. I didn't know if there's anything else that had come up since any of those touch base calls that impacts this measure. Okay, so the final slide is just a reminder about your third and final PDSA, and that is due on Wednesday, June 20th. I can't believe we're at the end of May already and moving into June. So just a reminder that this is due, and then shortly following that, we do have the next action period call. That's on June 26th, same time, same place. But this time we'll be talking about vaping, and then have our same data review discussion. And I'll pass it over to Kristen in case you have any other comments you want to do as we wrap up today's call.
Yeah, I just wanted to make sure I reminded folks of that action period call. You should be getting additional screening tools in the mail if you haven't already. So those were requested back probably around the 10th of the month, so be on the lookout for those. And then just to check in to see if there are any additional questions or items that have come up over the past month that we could try to be helpful with. Okay, if not, we will wrap up the call a few minutes early today, and I will make sure to send around the slides from the call, and then also a recording will be posted on the program page, so if you have any colleagues that are participating in the project who weren't able to attend today, they can review the call online. So thank you again for all your work on the project, and please don't hesitate to email if you need anything in the next month before we have our next call. And thank you all.
Thank you.
Thank you.